Welcome to this online webinar, Tracheostomy Refresher, Emergency Paediatric Care Scenarios by SBK Healthcare, and sponsored and delivered by the Directors of Respiration, Billie and Ranjeeta Devi. To find out more about further educational podcasts, webinars and forums, please do visit our website at sbk-healthcare.co.uk.
Hi there, as Vanessa kindly said, my name's Billie and this is Ranjeeta, and together we're Respirational. And we formed this company after realising that there was a shortage in tracheostomy training, particularly in our local areas in the community. We started our careers as acute respiratory nurses at Great Ormond Street, and then have gone off to do various different things in the meantime. Ranjeeta is currently a nurse in a special school, and I'm still a respiratory specialist nurse in a hospital, but we do respirational as well as that. We offer training up and down the UK in schools and community areas, and so if that's something that you think that you might be able to make use of, then please do get in touch. But anyway, that's not why we're here today. We're here today to talk about the tracheostomy refresher and some emergency care scenarios. So let's get down to business, and I will open our I'll share our presentation with you. Hold on just a second. So hopefully you can all see those slides. So as I said, it's a tracheostomy refresher, and we're talking about emergency paediatric care scenarios. So the things that we're going to cover today, a little bit of health and safety, what a tracheostomy is. Many of you will already know, but we'll just go over some of the basics. We're going to look at safety checks in the emergency box, a little bit on suctioning, humidification and stoma care, travel and transport, and then we'll spend a little bit of time going over the emergency algorithms and some practical scenarios and how you might approach them. So first of all, what is a tracheostomy? Of course, many of you will already know that, but a tracheostomy is basically a hole that we call a stoma that's in the neck, and it's in between the third and fourth cricotracheal rings. And in this position, it bypasses the upper airway. So it's below the nose and mouth, of course, and it is below the voice box. And it sits in the airway, which of course is in front of our esophagus, so our food pipe. So it doesn't go anywhere near our food pipe. It's much further below that in our airway. And you may notice, if you've looked after children with tracheostomies, that they might have no voice or very minimal and a croaky voice, and that is because where the air is flowing in and out of the stoma site, it's below the voice box, so the air isn't passing through that voice box, and so you don't get any voice. And also, because the air is flowing in and out of the tracheostomy in this position, the children often don't have a normal sense of taste and smell and things like that. So it's just worth bearing in mind, if you're caring for a child with a tracheostomy, that it affects them in those ways as well. So the main reasons that children have a tracheostomy is usually either due to airway obstruction or for lung protection. So particularly patients that perhaps have had neurological problem, which means they might not be able to swallow or protect their airway in that way. They might have a tracheostomy with a cuff inflated in order to prevent secretions going into their lower airway. Or it might be because they might need it for long-term ventilation, and a tracheostomy is just a very safe way to do that. So various different reasons why children might have a tracheostomy, and within those subsections there are so many different reasons within that, but yeah, they're the main headings of what we would consider are the reasons for needing a tracheostomy. So then there are also lots of different types of tracheostomy tubes, and we just don't have time to talk about them all today, but we're going to talk about a few of the main ones. So generally speaking, we have uncuffed tracheostomy tubes, and you might see them with the flexed end on the end. I'll show you some pictures of those in a minute. Or you might have a cuffed tube, And they generally come with three different types of tubes. So like three different types of cuffs. So a water cuff, a foam cuff, and an air cuff. And so we'll go through those in a little bit more depth. As I say, that list isn't exhaustive. There are other types of tracheostomy tubes. We just don't have time to cover them all. So the first tube I wanted to talk to you about was a bivona flex end tube. And this is a really common tube that we see in paediatrics. We use it often because it's really nice and flexible. And with that extension on the end of it, you can see where it's the one with the blue background. You see where the wings are. It has just a couple of centimeters of extension to where the entrance of the tube is. And for the reason for that is most children have these tubes put in when they are babies. And babies have like quite chubby necks, and their necks are a lot shorter. So that extension on it just gives length in order to be able to access the tube. Although they're really nice and flexible, what we don't want is these tubes to kink or flatten. So they have a wire coil that goes all the way through the middle of them, which means that they can still be really nice and flexible, but just without squashing flat. But because of that, they can't go in MRI scanners. Now, of course, for most of you in the community, that's not a problem. It's just something that's interesting to know. So that's our bivona flexed end tube. And you can get just the bivona tube, which is almost exactly the same, but just without the extension on it. But they tend to be a bit of a white colour, so often get mistaken for different types of tube, but they are still bivona tubes. All right, then. So that's the bivona flexed end tube and the bivona tube most commonly seen. And then the next type of tube that we see often is the Shiley tube. And the Shiley tube is usually considered our emergency tube. Some children do have this tube as their main type of tube, but often we see it in the emergency box as an emergency tube. And the reason that it's in there as an emergency tube is just that it's more rigid, and particularly with the introducer in it, it's much easier to insert in an emergency. And what you will find in that instance is that the tube is a half a size smaller than their usual tube that they use. So say, for example, they've got a size 5 tracheostomy tube. In their emergency box, they should have a size 5, say a bivona of exactly the same type. And then they'll have a size 4.5 of a Shiley tube as their backup tube. I'm talking about, for most children, this is what's usual. Obviously, there are exceptions, and for some children, that will be different. So bivona and Shiley tubes. Now, the next type of tubes we have, these are just two examples of cuffed tubes. So the tight to shaft tubes can also be bivona tubes. And it just, all the tight to shaft means is just that it has a cuff. And a lot of these cuffs are water filled, but you can get ones that are air filled as well. Cuff tubes are usually there. So it's a common misconception that the cuff is there on a tracheostomy tube to keep the tracheostomy tube in. But generally speaking, that's not what the cuff is there for. I think we make, as care professionals working with children with complex needs, we often mistake that, because with a gastrostomy, the balloon is there to help keep the gastrostomy tube in. But with a tracheostomy, it's really there for two reasons. One, it might be for secretion management. As we mentioned earlier, that's a reason for having a tracheostomy. So we can inflate that cuff to stop secretions basically getting down onto the chest. And the other reason is often for children that are ventilated, you can inflate that cuff if you're not hitting the kind of pressures that you want to. It just creates a seal around that airway and enables you to achieve good pressures when you're ventilating. That's not to say that every child that's on a ventilator will need a cuff tracheostomy. It's just that some do. I'm sure there may be some other reasons for a cuff tracheostomy tube, but they're the main ones that you'll come across. So that tight to shaft tube is your water cuff tube, and we've been over a couple of reasons why. Now, another type of cuff tube you'll come across is the foam cuff, and it's there for the same reasons, but it's just a much more gentle cuff. So this foam cuff, it kind of is auto-expanding, if you like, in the same way that a memory foam mattress is. So if the foam inside the actual cuff there is just like the foam in a memory foam mattress. If you press on it, it compresses, and when you release the pressure on it, it just expands into the airway. And because of the way it works like that, it just instead of the water cuff where you inflate it and you cause pressure in the airway that's pushed against it, with the foam cuff, it just expands gently to meet the space that it's in. And so it's a much nicer long-term solution for a cuff tube. However, the reason that we don't use them all the time is that they're a bit tricky in an emergency situation to take in and out. You have to deflate the cuff, and then if you take the syringe off, it will just re-expand back again. So with the proper training, it's not too tricky, but if you don't know what you're doing with them, they can be a bit difficult to take in and out. And even with the cuff deflated, the sponge on it can be a bit bigger and a bit bulkier than other tubes. You'll see at the bottom, it just says you need a syringe and 3-way tap for them. That is for that reason. If you take off the syringe, they re-expand. So what you can do is suck out the air from it, turn your 3-way tap to off, and then you can remove your syringe so you don't have that hanging off it. And then you have it secured so that the air stays out of the syringe. So yeah, just a little bit more tricky to use. So that's 4 of our main types of tracheostomies that you might come across. So we've spoken through already a few of the reasons why. So for that we have a cuff tube. So for ventilatory support, to protect the windpipe and the lungs from like secretions coming onto the airway, and you can use them to help wean patients off their ventilators as well. So we're going to move on to like a little bit of health and safety and our daily checks and things that we need to make sure we're doing with children with tracheostomies. And we can use this to remind us of what to do, our 4 T's. So these are checks that should be happening every single time that we take a child with a tracheostomy into our care. So it might be that they arrive in school and these are the first checks you do with them, or it might be that, say, somebody's popped off to lunch and you're now looking after that child, and you need to repeat these checks as you're now taking over the care for this child with a tracheostomy. So the first thing that we need to check is the tape tension. So we just slide a finger down the back of their tapes, and are their tapes the correct tension? Are they tight enough? Are they too tight? And we should just be able to slide the tip of one finger in between the tapes and the neck just to make sure that it's the correct tension. The next T is the tube patent. So can we suction that tube? Is it in? Is the air flowing through it? We should then also be checking our emergency box. So is the emergency box there, and has it got the correct contents? We're going to talk about the contents of a trachea box in just a few minutes. And then the last T is their tube chart. So a lot of children will have a bed head if they're in hospital, or they might have it in their classroom area or at home by their bed. And it's a chart that just tells you what tracheostomy tube they've got in, what size it is, when it was last changed, how far you should suction to, and it's just a safety measure and like a quick reference tool that you can use. And we should be having those with each of our, that should be going everywhere with our child with a tracheostomy. And then additionally to our 4 T's, we should also be checking our suction equipment and our catheters. We should be checking a saturation monitor if they've got it, making sure it's charged and that the parameters are set correctly. Not every child will have one of these, but if they have it, you need to check it. And the same goes for oxygen. If you've got oxygen, you need to check it at this point, but not every child will have it. So if you don't, then you don't need to check it. So these are all of our checks that we need to do when we take a child with a tracheostomy into our care. So we'll just take a little bit of a further look at the trachea box. A lot of children's trachea boxes will look like this, a nice blue case, but you will also see red tracheostomy bags. And as a child's been out of hospital for a longer time, these bags get broken and they end up with just a lunch box or whatever else. We've seen all sorts of things on our travels, but as long as you know and everybody that cares for that child knows what their tracheostomy box looks like, then it's okay. So this is just an example of what should be in your standard Bivona FlexStend tracheostomy box. Now, these pictures with the details of the contents are available on the Tracheostomy Safety Project website, and they have a different one for each of the different types of tracheostomy tube. They're really, really handy, and lots of children have them actually stuck inside their tracheostomy box. It's just a quick reference, so you can match the things to the pictures, or you can use the the list down the side to check off your tracheostomy box contents. So just to go over this one briefly, as we've already discussed, you can see on the screen there that you've got the, on the right there, you've got your same size tube. So your same size as the tracheostomy that's in. And on the left-hand side, you've got your spare Shiley tracheostomy tube, and that will be your half a size smaller. If your tracheostomy boxes, like if the boxes that they come in aren't there, you'll notice that on the wings of the tracheostomy, it will tell you whether it's an adult, ped, or neonatal tube, and that's important because that it depends on the length of the tube itself. And then it will also tell you the size. So we were talking about size 4 or 4.5, 5 tubes, and that refers to the diameter of your tubes. Can be a little bit confusing because often tubes will say ID or OD on there, and that stands for inner diameter or outer diameter. And when we talk about the size of the tracheostomy tube, we're always talking about the ID, the inner diameter of the tube. So we should have the correct size tube exactly the same as they will have in. We'll just say it's a size 5. And then your Shiley tube would then be a half size smaller. So for example, a size 4.5. Then in your box, we'll also have your tracheostomy tapes. So you can re-secure the tube if you've had to take it out. Scissors to cut the tapes. Lubricating jelly to help the tube slide in if you're having difficulty getting it back in again. And also a suction catheter. And of course, with the suction catheter, we can use it for suctioning in an emergency. But the real reason it's there is for something called the Seldinger technique, or railroading, if you like, which is basically where you insert the catheter into the tracheostomy, and then you can use the catheter to guide the tracheostomy in an emergency. Don't worry if you don't understand what I was just talking about. We are going to show you a little video of that later on. But that's really what the suction catheter is there for in your emergency box. But we'll forgive you if you do use it for suctioning in an emergency. So then these, so the rest of these cards, you'll see that they have them for all different types of tracheostomy. So this is an example of the same thing, but for the foam cuff. You'll notice a few extra bits in your foam cuff emergency box. So your 3-way tap, a syringe to deflate the cuff. And with a foam cuff, we've actually got an extra type of tube there. So you've also got another cuff tube that's not a foam cuff that you might need in an emergency, just because of the difficulties I was talking about with the foam cuff of deflating it and inflating it again in an emergency. So you do have a different spare there if needed. And the same thing for a Shiley tube and for a water cuffed tube. So a few different types of examples, and they're all available on the Tracheostomy Safety Project website. Really handy website to go to if you ever want any of the algorithms or any advice and guidance on tracheostomies. So we're going to move on now and talk just briefly about suctioning. So firstly, why do we suction? So we want to clear the secretions out of the airway. So if a child's trying to breathe and they've got lots of secretions in their airway, we've got to get them out. And things that might tell us that we might need to suction is they might have noisy breathing. We might be able to see secretions there. Sorry. It might be making them really like irritable and grumpy. They might not, they might be distressing them that the secretions are there. Their breathing might get faster or slower, which is probably worse. And you might, and we're getting into the more sort of severe end of things now, you might see a change in their saturations or heart rate. You might see their colour change. They might go pale or start to look a bit blue. Or if they're stressed out, they might be starting to look a bit red and, uncomfortable. We also need to look out for, so although we might hear noise, which might indicate that you might need suction, we also might hear no noise, which is a bigger worry because it could mean that the tracheostomy is completely blocked. We might see like nasal flaring. So if they're really trying to suck air in, even though a child with a tracheostomy isn't breathing through their nose and mouth, they still have the same responses to try and get air in. So you might see that whilst trying to get air in. And you also just might see the chest not rising and falling normally. And they're all indications that we might need to suction. So it's something that can't be delayed. If we notice a suction is needed, we should do it immediately. And when we suction, we should be looking at anything that's different for them. So anything that's not normal for that particular child, and that could be different depending on who you're looking after. So we need to look at frequency of suctioning. So some children will get suctioned a couple of times an hour, and that's normal for them. And if you're noticing that all of a sudden they need suctioning every couple of minutes, then we need to be worried. Some children might get suctioned once a day, and that's normal for them. And if we're noticing that it's more or less than normal, we need to notice that for them. We need to look at what the secretions look like to us. Is the colour different? Is the consistency different? Is the frequency of suction or the volume of secretions that's coming out different? Or are they difficult to suction out? And these could be signs of infection, could be signs of that they're maybe just dehydrated. A lot of children with tracheostomies are tube fed. And so in the hot months, are we making sure that we're increasing their fluid intake as we would naturally for ourselves? And that could be affecting their secretions. And are we struggling to get them out? Are they getting so gloopy that we can't get them out? Because all the time that we're doing this suctioning, we're trying to keep the patient comfortable, but what we're really trying to do is avoid that tube from getting blocked. And if we think that we're getting to the realms of that, we need to intervene, and we'll talk a little bit more about things we can do for that in a minute. The other thing that we might see is pinky or sort of flecks of blood in secretions, and that might be an indication that there's some damage to the airway. It could be following a tube change, or could be that there's something like a granuloma forming in the airway. So we just need to be a little bit aware of that too. So a couple of things just to be aware of when we're suctioning. We need to make sure we never suction beyond the length of the tube, because we can cause trauma deep down in the airway, just at the end of the tube. And if we do that, we can cause, like redness and bleeding. And in the worst case scenario, a granuloma can start to fall. So a little lump of like scar tissue in the airway. And in time, they can grow big enough that they can actually block the end of the tube. So really important to never suction beyond the length that we have been told to suction to, and never twiddle our suction catheters, because that can also push the catheter out the end of the tube. So yes, and then the other thing about suction catheters is that you'll notice in the picture, you can probably see that it almost has like a ruler on it, like it has like a length measure along the length of the catheter, and that is what we can use to guide us with how far we can go down the tracheostomy. But the other thing you'll notice about these suction catheters here is that they both have like a coloured end on them at the tip of the suction catheter. And the reason for that is it's an indicator of the different diameters of the suction catheter. And depending on the size of the tracheostomy, we should be using different size suction catheter. The reason for that is we never want to have a catheter that's more than half of the diameter of the tube, because it blocks the airway, and it means that the child can't, we're occluding the airway that the child's trying to breathe through. So, for example, if you have a size 3.5 tracheostomy, your suction catheter should be a size 7 suction catheter. If you have a size 4 tracheostomy, you should have a size 8 suction catheter, and so on. But if you don't have that size, so say for example, it's uncommon to find a size 9 suction catheter. So with a size 4.5 tracheostomy, of course, what we would want is a size 9 suction catheter. If you can't get a size 9, you should always round down to a size 8 rather than rounding up to a size 10. I hope that makes sense. It's a bit difficult to explain without being able to actually show you the suction catheters. So I just want to show you a very short video of what suctioning should look like, and it's courtesy of the Tracheostomy Safety Project. So this is just a really nice video of how to suction. So you can see here they're just checking their suction pressures there, and there is guidance about different suction pressures for different ages of children. You can see that she's keeping her suction catheter in the packet right up until she uses it, so not to get the tip of the suction catheter dirty. Taking off any HMEs, or in this case a ventilator, so you can get to the tracheostomy, and going into the correct depth to suction and no further. And she applies here the suction pressure on the way out. So we have the suction pressure off on the way in, and we have the suction pressure on the way out. Lovely. So you can, so that's just a little example of how to suction, and you'll see there that she didn't go further than she should have, and there was no like twisting of the suction catheter. So I'm just going to talk to you very quickly about humidification. So I guess the question is, what do we mean when we say humidification? What we mean is the amount of moisture and the heat that is in the air that a child with a tracheostomy breathes in, because usually the nose and the mouth for people without a tracheostomy provides that heat and that moisture. So as we breathe in, the nose and mouth heats the air and provides moisture to the air. So by the time it reaches the lungs, it's nice and humidified. But children with tracheostomies don't have that. Their air goes straight into the tracheostomy. And because of that, the air can get very dry, and it can be very cold, and then the secretions can get thick. So we're at risk of getting a blockage of the tube. Also, bacteria likes really thick, gloopy secretions, so we're at increased risk of infection. And also just generally the viscosity of the secretions can increase, and it's uncomfortable. It can cause the child to cough. So for those reasons, we want to keep the tracheostomies humidified. And we can do that in the most basic way with an HME, or you might hear it called a Swedish nose. And this on the screen, you can see some examples of a few different ones, and there are other ones available. But starting from the left, this tube just has like a little piece of corrugated card wound up in the middle of it, and it's below for children below 10 kilos. And then the humidivent is for 10 kilos and over, but it's basically the same. And then you have the tracheofoam, which is more foam-like rather than the corrugated paper. And this also can have oxygen attached to the side of it, and you can suction through the middle of it. And then you can see the Buchanan bib on the end, which is really good for children. I'm sure many of you have looked after children that have learned to pull their Swedish nose off and throw it on the floor, because it gets everyone's attention really quickly. So for those ones, or actually we've got a child that uses a Buchanan bib just because they're a bit self-conscious and they don't really like people looking at their tracheostomy, so they wear that over the top as well, and it acts as acts as their HME, but it's also then providing them with some privacy as well. So that these provide humidification, and the way they do it is really simple. It's a bit like, when we've all been wearing masks a lot over the last couple of years, and when you breathe into your face mask over time, it gradually starts to get warmer and wetter, and when you breathe back in that heat and that moisture, you just breathe it back in again. That's exactly what these HMEs are doing. So it's just a really nice and simple way of creating humidity for children with tracheostomies. Now, another way that we can create humidity, so say we've already got to the point where we've got thick, gloopy secretions, what can we do? Well, we can give a saline nebulizer. Most of you will know what this is, but for those of you that don't, it's usually just 0.9% sodium chloride, and you put it into the chamber and it vaporizes that salty water. And obviously itself, it has moisture in it, so it creates humidity, but the salt in it then draws further water into the airway, just helping to loosen the secretions. Of course, if you've got to a point where your tracheostomy is already blocking, then we wouldn't use a saline nebulizer. We would be then into our emergency scenarios. But these are just for use if the secretions start to get thick. It's important to note that not all children will use these. Some will have them regularly and every day, and some children won't use them at all. And just a brief couple of notes on stoma care. So we can't show you today an in-depth tape change or anything like that. Firstly, we don't have time, and secondly, it's just something it's quite difficult to show in this sort of format. But a few important notes. Our tracheostomy tape should be changed every single day. This tube is absolutely imperative to this child's breathing, and so we have to keep the neck and the stoma site nice and healthy. So we should be checking that the tapes aren't too tight, as we discussed earlier, and we should be changing them every day. And when we change them, we should be looking for like redness, rashes, inflammation, if the child's discomfort, and any signs of infection like smell and temperature, and if the child's getting drowsy. And as you can see on the neck of this child, it's really starting to look quite red, and these are all things that we need to be looking for. And at worst case scenario, we can get a granuloma, which is what this is shown in this picture here. And this is a granuloma that's quite far down the line, so it's quite big, and it's it's already started to look like normal skin. In the early stages, they'll look red and shiny, and they can bleed a lot, and we should be treating them in those early stages, but not when they get to this stage. We should have already dealt with them at this point, because at this point they might need a surgical intervention. But you can see how dangerous they are. At that size, they can actually even block the airway. So if you start to see lumps of forming around the tracheostomy site, really important to raise that to their care team, to the hospital team straight away, so they can deal with those granulomas. So that's all I wanted to talk to you about the background of it. So we're now going to move on to a few other bits, and Ranjeeta is going to take over, talk to you a little bit about travel and transport, and then our emergency scenarios.
So travel and transport is an important part of taking out a tracheostomy patient. There's an acronym that would go through what we need to do in regards to being prepared for taking that tracheostomy child out. Really good things to remember, to make sure that you are covering all aspects of taking that child out. So to be appropriately trained and to be confident in all aspects of that care, to know about your environment, to know where you're going. Are there any plug sockets? Are there anything that you can recharge your batteries if you need to making sure that you're packing your bags carefully and sensibly, making sure that you haven't got your lunch on the top of your suction unit or your trachea box, just making sure that everything is easily accessible if you do need them in an emergency. To always rethink your travel and your journey and your activity if your child or your young person isn't feeling very well, or they're just not really their self today. Emergency equipment, making sure they're fully charged, making sure that you have everything that you need for that trip. Preparing as well for any clinical emergencies that you may get on the way, having escalation plans. Risk assessments are so important when you're taking out tracheostomy children or young people out and about. So just making sure that you know and that you've risk assessed where you're going and what to do if your equipment fails, or if there's a fire evacuation, or for some of the communities, if you're taking out some of the, you're being that carer that's going out with a parent, to whether it be a hospital appointment or anything like that. What are you going to do if that car breaks down as well? So just thinking about those sorts of things. Alternative power sources and equipment, thinking about where you're going and if there are alternative power sources, if there's any internal batteries or battery packs that you need to have fully charged, they're really good to have and to know that they're ready to go as well. Restocking and recharging your equipment when you do return, really, really important. I know so many times you can come back and you forget to plug in that cable to be able to have it charged, but just making sure that you do that. And that can also be on something like a checklist that you do for each individual child or young person when you do come back, just making sure that you are recharging that equipment. Also making sure that you're taking enough supplies as well, making sure you've got enough suction catheters. If the child is on oxygen, just make sure you've got the oxygen. If they're on nebulizers, make sure you've got enough nebulizers, and also external batteries if you have them for your ventilators. Always making sure as well, if you're driving, that that you're actually the independent person that's looking after that child and young person. You'll always need a second trained adult to be able to take them out. There'll be one that's a driver and one that's trained with them to safely take them out. Tracheostomy basic life support. So these two care plans that Billie spoke about briefly earlier are the care plans that you will see. More so the one on the left-hand side, you'll more so see that in community settings, and the yellow one that you'll see alongside that in a community, but also you'll see that a lot more in hospital settings as well. What we're going to do is we're going to briefly go through each of these scenarios for you. With basic life support, this will obviously show what actions that we will take in regards to having a blocked tube. You'll still go through your basic life support as normal in regards to safety, checking that your area is safe for you to approach, stimulating, shouting for help, and suctioning that airway and making sure that it is clear. If that tube is blocked, then you know that you need to immediately change that tube. If you can suction that tube after, or once you've replaced that tube, to ensure that you've suctioned. You need to assess for breathing, and you look, listening and feeling for up to 10 seconds. You're making sure that you're doing that over the actual tracheostomy site. You're giving rescue breaths. You're giving those 5 rescue breaths to be able to give those rescue breaths, and then checking for signs of life after you've given those rescue breaths. Are they pink around the lips? Is there any movement? Are there any normal signs of breathing? If there aren't after that, you then will go on to your chest compressions. And after that minute, you'll do that for 1 minute or a cycle of 4, and then you'll go back and reassess. It'll also go through the action that you'll need to take as well if that tube fails to go in. So as Billie mentioned, it's the reason why you have that half a size smaller tube in. So if you're unable to get your first line tube in, you'll go in for your half a size smaller, which is generally your Shiley tube. You will then also, if you can't get that Shiley in, you will then attempt to pass it through your smaller tube with a Seldinger technique, and you'll use that suction catheter as a guide. And we'll go through that in a little while as well. And if that is unsuccessful and you're not able to get the smaller size Shiley in that Seldinger technique, then we need to know where to ventilate the child via the nose and the mouth if they do have any underlying conditions. The reason why it's really important on the yellow charts to make sure they are really completed with the patient-specific details is for this reason. If you don't know where to, if they don't have an upper airway, it's really important you know where you need to give those rescue breaths, because it will either be via that nose and mouth or it will be via the stoma site. On this chart, like we spoke about, it's really important to know the suction length they go down to, and where it says your upper airway abnormality. It's really important you make sure that that's completed as well. And if that isn't completed when you're going to see your patient in the community or your patient in hospital, just make sure that you find out where that information is and document that as well. So moving on to scenarios now. So we're going to go through some scenarios, and we'll have some polls. So these emergency scenarios are very typical scenarios, and it's really good for us to think about what scenarios that we could possibly be in. So scenario 1 then, we have a 3-year-old boy with a tracheostomy. He's had a 2-day history of cold, runny nose. He coughs and then starts to look blue around the lips. You suction and the catheter will only go down to 4 centimetres when the usual suction catheter length is 8 centimetres. What do you do? Sarah, are you able to launch the poll, please?
So if everybody could vote, that would be great. Lovely.
Amazing.
So we're getting lots of votes coming in here. Wonderful.
So the options that you've got are A, give a nebulizer, B, change the tracheostomy, or C, give 5 rescue breaths.
Great. I think most people have voted now.
Amazing.
Yeah.
So we'll just end that poll now, and then we'll share the results. Great. So we can see that a lot of you picked change the tracheostomy tube, which is brilliant. And we'll now show.
Yeah, lovely. So that's absolutely correct. And this is just a little video to demonstrate that changing of the tracheostomy tube. So you can see they're going in with the same bivona tube that they just took out. So it's exactly the same type, rather not the same tube. So a nice smooth change there on that tube.
Great, well done.
Well done, everyone. Whoop, there we go.
Okay, and you can see on the algorithm that it will show that if the tube is blocked, then you need to change that immediately. Scenario 2 then. So a 14-year-old girl with tracheostomy and CCHS wanted some privacy, so she went to the bathroom alone. She's been gone a little too long, so you go to find her and she's unconscious on the floor. You check her trachea and it's in, and you can suction to the correct depth. She's not breathing, so you give 5 rescue breaths and her lips get a bit pinker. Sarah, we can start this poll. What do we do next? So a couple of the answers that we've got. So do you A, give further rescue breaths? Do you B, change the tracheostomy tube? Or do you C, start CPR? So we've got a lot of the answers coming through, which is great.
Well, we've got some indecision going on here. A lot of you think it's A and a lot of you think it's C. Yeah, really nice. Some great answers there.
Well done.
Good. I think that's most people that have answered. Brilliant. There.
So we'll just end that poll there and we'll share. Great. So the correct answer here was to give further rescue breaths. And the reason why you'll do that, and you'll see in this video, is just to help and assist with that breathing. So some of the answers were where you'd notice about changing the tracheostomy tube. The clear indicator there is where your tube was actually still in and it was suctioning down to the correct length. So giving those rescue breaths just to assist with that breathing is what that girl would need.
Yeah, because I think what we notice about that one is that we gave our initial rescue breaths and their lips went a bit pink, so they were showing some response there. So what we know is if we start to see some response and their lips going pink, we know their heart's beating at that point. So what we can do to support is give further rescue breaths. And if we didn't see a response at that point, then those of you that said CPR, yeah, you're absolutely right. If we hadn't seen a response from our breaths, then we would start CPR. But because we saw that pinking of the lips, we can give further rescue breaths just to support. All right, then. Let me move us on to the next scenario. Doesn't want to move us on. There we go.
Great. And in regards to the algorithm, you'll notice that you're giving those rescue breaths and you continue to give them until they go back to their normal breathing. So last scenario then. So this is part one of the scenario. So you've got an 8-year-old girl with a 5.0 bivona flexing tube in situ. They come to school on the school bus, and on arrival, she's quite lethargic and she's less responsive than usual. You check her trachea and it is out. You get the emergency box and you try to insert the spare bivona tube, but it won't go in. What do you do next? Sarah, if you could launch this poll for me, please. So with the answers to these, so you've got A, the option is give breaths via the nose and mouth. B, try the cell dinger technique or railroading. Or C, try the smaller Shiley tube. So everybody's getting those answers
almost unanimous voting here.
This is great.
Really good.
Brilliant. So we'll take off the poll, just letting off a couple of you coming in. And we'll call it there. Brilliant. So sharing those results now. So the majority did say try the smaller Shiley tube. And that's correct. And what you'll see here is that the Shiley tube will then go in once you've not able to get that bivona in. So that's brilliant. That's the correct technique. And what you also notice is that it will say that on the algorithm as well. When you can't get the first line tube in, you will go in for your half a size smaller. So the second part of this scenario, so then you try to insert that Shiley tube, but that also won't go in. So what do you do next? And just put through that last poll then for us, Sarah, please. There we go. So your last three options then, do you A, start CPR? Do you B, try the cell dinger technique, railroading? Or do you give breaths via the nose and mouth? And it's another unanimous decision here, isn't it? So it's great. So get a few of you more in for those answers.
Oh, we've got some people changing their minds.
Oh,
here.
yeah.
A few different votes coming through. Good.
Brilliant. And we'll just end that poll there. Brilliant. And so you're correct. So B, try the cell dinger technique or railroading. If you're not able to get that Shiley in, the aim would be is that you would railroad your Shiley in with your suction catheter as a guide. And you'll just see in this video that she's just popping in the suction catheter through the Shiley tube, using the suction catheter as a guide to insert that Shiley tube in. And then she'll take out the suction catheter in that part. Brilliant. And again, says it on the algorithm as well. So if you can't get your first line tube in, you go in and attempt the smaller size tube in your stomach using that suction catheter and that cell dinger technique. Okay, so well done to everybody who got that one right as well.
Great. So that was a real whistle-stop tour of the things that are current in tracheostomy care and a few emergency scenarios for you. And so, yeah, hopefully now we've got 15 minutes just for some questions. I will stop screen sharing so you can, so we can see you all a bit better.
Hello. Thank you so much, Ranjeeta and Billie. That was brilliant and very interesting. I can see all the questions coming in through the chat box, so I'll get started. The questions are just on my second screen, so if I look a little cross-eyed, that's why. So, someone's asked, can I ask why you would suggest having a Shiley as a size smaller rather than the same make they have?
Yeah, absolutely. So the Shiley tube it's a much stiffer tube than the Bivona tube. So the Bivona is a really nice tube to have as your everyday tube because it's really soft, really flexible, and it doesn't cause any damage to the airway. But in an emergency, it can be just a bit too flexible. So and then if the, say for example, the muscles around the stoma site have gone into spasm, it can be hard to put a Bivona tube back in again. So in that instance, we would use a Shiley tube if we couldn't get the Bivona in, just because it's just a bit harder and just easier to push into a stoma site that's perhaps gone into spasm or closed up and you're finding it hard to get in. So that would be why you would choose a Shiley tube for that.
Oh, thanks, Billie. So I've got two questions that are similar about procurement. So someone asks, is anyone having problems getting hold of Bivona tubes? Is there anything that you've done to help? And then another asks that there are stock issues with tracheostomy dressings and Capitex. What other dressings would you recommend?
So I'll talk about the tubes in the first instance. So yeah, it's been a problem that's been ongoing now with a supply issue with the materials for the Bivona tubes, and so we're running on real shortages at the moment, and so as far as I'm aware, as it stands at the present, the manufacture of them has restarted as usual, but because there's been such a shortage, the backlog it's still going to be having effects of shortages until next year. But there is let me just have a look for you, because I was actually reading some guidance on this earlier. So the British Association for Paediatric Otolaryngology have released some guidance as to what to do in this situation. And for most patients, what they're advising is that they be switched over to a different type of tube. And I imagine that would be their leading care team that would be responsible for doing that. So most patients, if they've run out of Bivona tubes, should be switched on to something else. However, the guidance does accept that some children that's not really possible or sensible for, and in which case there is guidance as to what to do in that situation as well. So yeah, much more important people than me have written that, so I won't try and explain it all to you. But yeah, if you look for that guidance on it's called like a risk stratification tool. If you search for that, and maybe I can share the link for it as well later, then the guidance for that is there. In terms of the dressings and things, the answer is I don't know exactly what different types are available, because neither of us have jobs where we work in procurement. However, I do know that there are lots of different types of dressings that are available on NHS supply chain. I think it's a case of having a bit of a Google and seeing what you can find and seeing if you can get hold of them. But yeah, the truth is I don't know with those what else is available.
Thank you. So the next question, again, is a two-part question. I've tried to marry them together as much as do you have one-way valves in your blue box or ambulatory bag with box if ventilated? We also provide Velcro ties for emergency single-person tracheostomy changes. Then another comment about providing Velcro tapes for an emergency situation for someone who normally uses twill tapes is interesting. Is this common practice?
Yeah, absolutely. Do you want to answer that one?
Yeah. So in regards to the one-way valve, absolutely, you would still have that in your tracheostomy box. If some of the, like they mentioned about the ventilator patients, that yes, a lot of them will have bag valve masks, and they'll be correctly trained to be able to give those rescue breaths via bag valve mask. The one-way valves that you do have, we recommend them, and they should be in every child or young person's box. Emergency kit, the Velcro tapes, as the individual had mentioned, it is just for a single hand securing that tape, especially if they have twill tapes. So remember, that's just there purely in an emergency situation. And if you are by yourself, you can obviously change that tube yourself, but it's for you to be able to secure that tape and secure that tube. So that's the reason why you would have the Velcro tapes in, even if they do have the twill ties as standard. A lot of the community teams will probably know that depending on what area you're in, you might use Velcro tapes as standard in the community as well. So that's the reason why they would keep Velcro tapes and not the twill tapes. So it's just down to which area that you are, where your child and young person is. But 100%, you should have a one-way valve to be able to give rescue breaths via mouth to trachea. And obviously that one-way valve prevent any sort of secretions going into your mouth and things. And the ventilated patients will have the bag valve mask that they'll be safely trained on how to use as well.
Brilliant. And on the topic of tapes, I've got a follow-up comment from Jordana, who asks, do you not have sleek tape in emergency boxes?
I think that one is really trust specific. So I know some trusts use sleek, some have gone over to using Duoderm, some don't recommend any at all. And so because of that, because of the variations from trust to trust, we don't recommend anything specific, but yet lots of them do. Lots of them just go with a hand over the stoma site if you were to have to give breaths via the nose and mouth. So yeah, there are lots of different options there. But using guidance from the Tracheostomy Safety Project website, they don't recommend one in particular. So neither do we.
Okay. So, and then whilst we're still talking about emergency boxes, Lisa's asked, are there yellow trachea care plans meant to be kept in the child's emergency box?
Yeah, it's good practice to keep them in there. So the bed heads that I showed earlier about where it would say your patient's name, it would say what tube they have in, if they've got a bespoke tube, because some of them can be a little bit more longer than normal, and then they will have their suction length on there. And about the upper airway abnormality, it's really, really good practice to have them in the box. A lot of people stick them on the top, a lot of them stick them inside. Again, when Billie said they could be in the bags, in their red bags that they have, so it's really good practice to keep that, because, for example, where Billie mentioned I could go and cover a patient that she looks after all the time, and I might not know, or Billie might have forgotten to tell me about the suction length or anything like that, or if it's a bespoke tube. So it's really good to have that information to hand as a quick guide that I can have a quick look to read what that what the sort of bespoke information is for that child or young person.
Yeah, and it's often good to have like another copy on the wall or on your care plans, quick reference places, because if you need them in an emergency usually. So always just somewhere you can get hold of it quickly.
Yeah.
Thank you. So we have also got a question that's come in about the Seldinger technique. There's been a lot of conversation around this. Sarah's asked if anyone's actually used it in practice. Bobby said that they've never been taught it, but do they think that's due to just working in the hospital environment? Is there anything that we can talk about around that topic? Lauren asks, do you also teach non-registered professionals to use the Seldinger technique?
Yeah, I'll start to answer it, but if you've got anything to add, then please do, because there's quite a lot there and a lot to talk about. So yes, absolutely, that's a technique that should be used by everybody in the community, in hospitals. It's part of the accepted tracheostomy algorithm. It's in there, and everyone should be taught how to do it. However, I've never seen it done. Between us, we've got over 20 years experience of working with children with tracheostomies. And honestly, neither of us have ever needed to go any further than our Shiley tube. It's a really uncommon occurrence where you would need to get as far down your algorithm as to need the Seldinger technique. But it's obviously there because it has been needed by someone. somewhere, and if you're that unlucky person that gets that far down the algorithm and needs to use it, then you need to know how to do it. I think probably it's important to mention that the algorithms are also based on experience in adult care, and adult tracheostomies are actually formed in a different way to paediatric tracheostomies, generally speaking, and so we see a lot less of the situations where stomacytes close over in pediatrics, whereas it's seen a lot more in adults. And so possibly in adults they get down to that part of the algorithm more often than we do in pediatrics, but never say never, and absolutely it should be something that everybody's aware of how to do. Have I missed anything there?
No. She's actually in regards to whether carers, sort of registered nurses or medically trained versus non-medically trained individuals, everybody gets taught it. Anybody who gets signed off, it is a part of the competencies that Billie can tell you a little bit more about, but in regards to the panel Thames London documents, it is a part of the key skill. It is a key skill that we show on dolls to be able to get that signed off, but it is a key skill that needs to be signed off. So regardless of whether you're a nurse, doctor, a healthcare professional, everybody has to sign off.
Okay. I've only got time for just a few more questions. So Trudy's asked, what do you use for the granulomas? And then I believe that Sylvia's followed up with, what do you use to treat the granulomas?
Yeah, should I take that one?
Yeah.
So us personally, we don't use anything because because our role really is training. So we don't recommend on that side of it, because it would be a doctor or somebody that's able to prescribe treatment for that would do it. But usually speaking, the first line treatment would be some sort of steroid-based cream in the very early stages in order to try and shrink it, because if caught early, they can be shrunk right down without needing to have any further intervention. I know that then in some areas the next line would be something like silver nitrate to burn it off. But of course, we're dealing with an area that's really close to the stomacyte. And so we shouldn't be doing any of these things without guidance from either their ENT team or their respiratory team. We shouldn't be messing around with the stomacyte unless we really know what we're doing. And then, of course, if it gets any further than that, then it would be a surgical intervention. But yeah, the most simple thing that we can do in the community is recognise them early and get them treated early with some sort of steroid cream, like a hydrocortisone cream or something like that.
Oh, okay, thank you. Amy Young has asked where you can get a copy of the yellow algorithms. Is it something that we could share perhaps to everyone?
Yeah, absolutely. Do you want to? Yeah. And so I'm taking all of these questions. I've got too much to say. So they're all on the Tracheostomy Safety Project website. And I think everyone's going to receive a copy of the slides, and the actual website is on one of the pages. And so it does say the website on there that you can go to get all of those bed heads and the algorithms and everything. It's a really great website to use, really good.
And some of the videos are on there if you wanted. Some of the some of the videos that we saw, we could only show clippets of it, but all the videos are on there as well. Really, really good, informative website for anybody really that wants to sort of refresh themselves.
Yeah, when you're talking about videos, there's some really realistic videos of like emergency tracheostomy tube changes and things like that. So if you want to see things like that in more detail, then yeah, a great place to go.
Thank you. I think that's probably all we've got time for questions wise, but I would just like to thank not only you and Billie, but also all of our brilliant delegates for writing so many questions and being so engaged. I did try my absolute hardest to get through as many as possible, but if you do have any further questions, you can always get in touch with the SBK team and we can pass them on. I hope that you've really enjoyed the session.